This week, our group was in charge of discussing the diagnosis of retinoblastoma. Our group consists of Leslie Fernandez, who discussed risk factors, Stephanie Hollister, who focused on patient outcomes, Joseph Eliason, who did the introduction, conclusion, and did the project formation and formatting, Courtney Holcomb, who did the what is the disease and the voiceovers for the group, Callie Everett, who discussed treatments, June Garcia, who did the introduction and pathophysiology, Kimberly Theus, who did the case study, Rosalind Domingo, who discussed the complications and signs and symptoms of disease, and James Gaynor, who discussed pathogenesis. Our case study involves a 4-year-old female who presents to the primary clinic with redness and swelling of the right eyelid for the past 2 months. Mom reports taking immediate care over the last couple of months for her daughter's eye and was prescribed steroids and eye drops. Mom noticed a slight color difference between the left and right eye. Examination showed white opacity when light is shined in the eye. Our 4-year-old is allergic to penicillin and has a family history of a maternal cousin who had retinoblastoma at age 2. Past medical history includes approximately 2 ear infections since the age of 1 and a green stick fracture at age 3. All immunizations are up to date. Retinoblastoma is a rare cancer of the infant retina affecting approximately 8,000 children per year. RB1 alleles mutate in a single susceptible cell, and loss of tumor suppressor functions leads to rapid, uncontrolled cell division. The RB1 retinal cell proliferation creates a non-malignant retinoma, and a tumor develops after changes lead to uncontrolled proliferation. With early recognition, retinoblastoma has a 95% survival rate in developed countries. However, the survival rate globally is less than 30% due to the high occurrence in middle to lower income regions. Retinoblastoma may have a heritable or a non-heritable factor, and more research is needed to study risk factors. If found and treated early, retinoblastoma is curable. If left untreated, invasion to the optic nerve and the brain can occur, and metastasis may occur especially in the bone marrow and cerebrospinal fluid. As of today, there are still very few risk factors that are known to be linked to retinoblastoma, and many are still being studied. The 2 most common risk factors associated with retinoblastoma include age and heredity. Retinoblastomas are mainly diagnosed in children 3 years of age or younger and are rarely diagnosed in children after the age of 6. Depending on age and heredity, retinoblastomas may be more commonly diagnosed in the first year of life if heredity plays a part in the family history. This is considered to be a congenital retinoblastoma. Non-heritable retinoblastomas are more commonly seen in ages 1 to 2. Children who have had a parent with a retinoblastoma have a greater risk in developing one at an even earlier age. Children with the hereditary retinoblastoma tends to occur in both eyes rather than just one. If a retinoblastoma is left untreated, many complications can occur. The tumor can spread to other parts of the eye, causing glaucoma and vision loss. If left untreated, the tumor can spread to the rest of the body parts, such as the brain, lymph nodes, liver, bones, and bone marrow. The image on this slide demonstrates a 2-mutation model of retinoblastoma development. In inherited or familial retinoblastoma, mutations of the RB1 gene on chromosome 13 and 14 lead to neoplastic proliferation of retinal cells. The first mutation is transmitted through the germline of an affected parent. The second mutation occurs somatically in a retinal cell, leading to development of the tumor. In sporadic retinoblastoma, development of a tumor requires 2 somatic mutations. According to the Nature Review's disease primers, understanding retinoblastoma molecule pathways could lead to treatment and prevention opportunities. Oncoproteins such as MYCN could be targeted in both RB1 and MYCNA tumors and RB1 negative tumors that have MYCN dependence. Furthermore, studies based on molecular discoveries showed that exposing retinoblastoma-prone murine fetuses to small molecule inhibitors of E2F or CDK inhibited subsequent tumorigenesis without disrupting normal retinal development. Retinoblastoma is usually found in children younger than 5 years old. It is very rare in adults. Leukocoria is the primary manifestation for retinoblastoma. Leukocoria is a white pupillary reflex which is also called cat's eye, which is due to the tumor behind the lenses. According to the American Cancer Society, normally when you shine a light in the eye, the pupil, which is the dark spot in the center of the eye, looks red because of the blood vessels in the back of the eye. In an eye with retinoblastoma, the pupil often appears white or pink instead, which is known as a white pupillary reflex or leukorrhea. Strabismus, also known as cross-eyed, is also one of the signs for retinoblastoma. This can be due to a weak eye muscle caused by the tumor. The eye is filled with a jelly-like substance called the vitreous humor. In front of the eye, the colored part of the eye, the iris, covered with a lens, acts like a camera shutter and allows light to enter the eye and focuses on the retina. The retina is the inner layer of cells in the inner posterior portion of the eye comprised with special nerve cells that is sensitive to light. The light-sensing nerve cells communicate with the brain via the optic nerve located in the outer posterior portion of the eye. The pattern of light that reaches the retina is sent through the optic nerve to the visual cortex of the brain, allowing for vision. Development of the eyes begins in utero. During the early stages of child development, the retinal cells continuously multiply to create cells to fill the retina. Eventually, the cells cease to multiply and become mature retinal cells. In retinoblastoma, instead of cellular maturation, the retinoblasts continue to multiply, leading to cellular mutation. The cellular mutation is initiated by biallelic mutation of the retinoblastoma gene, or RB1, in a single susceptible developing retinal cell, such as in early childhood. Inheritance of one mutant RB1 allele predisposes an individual to forming proliferation of RB1 allele, thus resulting in non-malignant retinoma. An intraretinal tumor develops after genetic changes in the retinal cell, leading to uncontrolled proliferation. The tumor is first detected through a white tumor visible through the pupil, also known as leukorrhea, which blocks vision. In congenital retinoblastoma, the mutation to the RB1 gene develops during early development in utero and occurs in 1 out of 3 children with retinoblastoma. Increased awareness by providers of retinoblastoma signs and symptoms, such as leukorrhea and strabismus, can increase early detection and referral to a specialist, which allows for prompt treatment to avoid metastasis. The American Academy of Pediatrics recommends performing a red light reflex test, which is when the clinician views the retina with an ophthalmoscope after birth and at healthy follow-up visits. If there is a family history of retinoblastoma, such as with our patient, screening should be performed following a schedule to ensure early detection. Indirect ophthalmoscopy with dilation of pupil by an eye specialist is usually sufficient for diagnosis because biopsy can increase the risk of metastasis. MRI is used to assess invasion of the optic nerve, and CT scans are avoided because of the risk of radiation causing secondary primary cancers in RB1 mutation carriers. To distinguish between differential diagnoses such as Coats disease, persistent fetal vasculature, vitreous hemorrhage, and to clarify the severity of disease, detailed retinal examination is performed under general anesthesia. Genetic testing and counseling is performed in order for patients to understand the risk and signs and symptoms of familial retinoblastoma. Numerous treatments exist for the treatment of retinoblastoma. The following treatments are considered to be the most effective. Photocoagulation involves laser beams that are directly applied to the eye and use multiple short burns to destroy the retinoblastoma tumor. The power of the laser beam is gradually increased until the tumor is opaque white and coagulate. Cryotherapy involves visualizing the retinoblastoma tumor and applying nitrous oxide directly to the sclera of the eye. The nitrous oxide freezes the tumor, and during the thawing process, the tumor cells die. Cryotherapy is effective in destroying small tumors at the primary site or recurrent tumors found in the retinal periphery. Plaque radiotherapy involves placing a radioactive probe on the sclera of the eye to deliver transscleral radiation over the course of 4 to 7 days. Plaque focal radiation is beneficial when used on a part of the eye that will not obscure vision. Enucleation refers to the surgical removal of the eye. The eye and optic nerve are removed. An artificial eye implant is placed in the socket. The eye muscles are reconnected to the implant so the eye can move. Enucleation is considered very effective in preventing metastasis of retinoblastoma. There is no standard chemotherapy regimen used to treat neuroblastoma, and each doctor has their own preference. Research has found that using a combination of chemotherapy produces the best treatment outcomes and chance of remission. Chemotherapy applied directly to the site of neuroblastoma has fewer systemic side effects and chance to preserve vision. Local delivery routes of chemotherapeutic drugs to the eye include intraarterial, intravitreal, topical, and subconjunctival. Patient outcomes are dependent on prompt diagnosis, referral to an eye specialist, and treatment which prevents retinoblastoma metastasis and enucleation. Education for family on signs and symptoms to avoid recurrence are important. Lifelong follow-up is necessary due to the increased risk of development of secondary cancers and recurrence of retinoblastoma. Social and emotional needs of child and family need to be addressed during and after treatment due to the possible financial and developmental burdens.